Good morning, everyone. Afternoon or evening, depending on the time of day that you're watching. This is Chapter 19, the Cardiovascular System, Blood Vessels. Blood vessels are a delivery system of dynamic structures that begin and end at the heart. Arteries carry blood away from the heart. The blood is oxygenated except in pulmonary circulation and in umbilical vessels of the fetus. One of the common misconceptions about arteries is that they always carry oxygenated blood, because we'll typically see them out in the body represented with a bright red color. Now, it's true in what we call the systemic circulation out to the body tissues. The arteries are carrying blood away from the heart to the body tissues in order to deliver the oxygen and pick up carbon dioxide. Now, keep in mind, when blood is going away from the heart to the lungs, the pulmonary circulation, that blood is going to be low in oxygen and high in carbon dioxide. So that is why you always want to think of arteries going away from the heart. Capillaries are the contact tissue cells, and these directly serve the cellular needs. In other words, they are bringing the oxygen and the nutrients to the cells in the body that are metabolizing or alive. And they are very, very tiny. Oxygen will diffuse out from the capillaries to the body cells, and carbon dioxide will diffuse into the bloodstream at that level. Then veins will be all those vessels that are carrying blood back toward the heart. And here is a generalized structure of an artery and a vein. It also says capillaries, but I don't see any capillaries here. This is an artery, and you can see right away one of the major differences here is that the artery is very thick. Its wall is very thick. Here's the inside. That inner area we call the lumen, or the space inside. And so you can see this artery in relation to the artery, and you can see the space inside the vein. It's actually pointing to the space inside, and here's the vein tissue right there. And this is a cross section, and because it's so soft, it kind of gets squished when they prepare the slide. And again, the lumen, that comes from the word light. Lumen is the light-colored part in a cross section in a prepared microscope slide. Because it looks light in the middle. It's empty. It's typically in the body, it's the central blood containing space. There's actually 3 wall layers in arteries and veins. You have from the inside tunica intima, then tunica media, and then tunica externa. And you can consider intima being the most inner layer. Media, obviously, it sounds like it's in the middle, and then the external layer going around the outside, which is, of course, inside the body. But a tunica refers to a tunic or a covering. Capillaries consist of endothelium. This would just be that inner lining of cells with a very sparse basal lamina. Basal lamina is a very delicate connective tissue to give support to those endothelial cells. And here is a generalized structure of arteries, veins, and capillaries. This time, this is a figure, and you can see it's a drawing. Here is an artery, very thick-walled. The arrows are representing the blood that's traveling through. And again, this is going to be out to the body. This is happening with systemic circulation, meaning out to the body. So here is the artery's inner layer, the tunica intima. Then you've got some sublayers there. Endothelium would be that very innermost lining of cells. It's a type of an epithelium that lines all of the blood vessels in the heart. Tunica media, very thick layer of smooth muscle. And there's also some elastic connective tissue. And then tunica externa has collagen fibers. And this is around the outside of the vessel. So over here is a vein. And with veins, they have the 3 layers again, but this tunica media is quite thin in relation to the artery. Then you have the tunica externa, which they're representing here in blue because this is out in the body, and the veins are carrying blood back to the heart. Between the arteries and the veins, you have capillaries, and this is showing a capillary network or a capillary bed, sometimes we call it, so that the blood that's carrying oxygen out in the body is typically represented with this bright red. And you can see it's kind of turning lavender here because this is representing, as these capillaries surround all the body cells, they are releasing the oxygen to the body cells and picking up carbon dioxide, and therefore we're seeing it represented somewhat in a blue color. So these we could say are arterial capillaries and venous capillaries, and then these collect into progressively larger vessels and return to the blood returns to the heart in the veins. And here's showing you a close-up of a capillary. So we're going to go through the tunics. Tunica intima really starts with that endothelium that lines the lumen. It's continuous with what we call the endocardium, which is the lining inside the heart. The endothelium has a slick surface that reduces friction. In vessels that are larger than 1 millimeter, there is a connective tissue membrane that will give support to this endothelium. Tunica media in the middle. This consists of smooth muscle and sheets of elastin because it needs to be somewhat stretchy. The sympathetic vasomotor nerve fibers, this is part of the sympathetic nervous system. These fibers will control this layer because it's primarily smooth muscle, and the smooth muscle is what can cause vasoconstriction, that means narrowing the blood vessel, and also vasodilation if there's a need for that vessel to enlarge. When this vasoconstriction and vasodilation greatly influences blood flow and therefore blood pressure. Tunica externa, or another name for it is tunica adventitia. The collagen fibers here protect and reinforce the vessel and also anchor it to the surrounding structures. It also contains nerve fibers and lymphatic vessels. So blood vessels, these vary in length, diameter, wall thickness, and tissue makeup. They are also very much associated with lymphatic vessels. So there is an interaction between the blood vessels and the lymphatic vessels, which is represented on this figure. So this is figure 19.2, and it shows the relationship between the blood vessels to each other and also to the lymphatic vessels. Remember, the lymphatic vessels are called lymphatics. And you can see this green is, obviously it doesn't look exactly like this in the body. This is a model to represent how these vessels are associated with each other and circulation. So you can see these as the lymphatic system, as the lymphatics, particularly the lymph capillaries, as they pick up excess body fluid, they will return that fluid back to the circulatory system through the lymphatics, and in the meantime it's also screening the lymph, the fluid flowing here, through the lymph nodes. So you can see all of these things represented right here. So with arteries, there's actually several different kinds. The very first type coming from the heart would be the elastic arteries. The elastic arteries have large, thick walls with a lot of elastin. Elastin, remember, is that protein fiber that's very stretchy. So these have all of their tunics, all of their layers have elastin in them. This includes the aorta and its major branches. They have very large lumens that offer very low resistance. These arteries do not respond with vasoconstriction, and they're pretty much what we consider pressure reservoirs. They can expand and recoil, meaning go back to their original size, as blood is ejected from the heart. And as we get to smaller and smaller vessels, this will decrease the pressure. So it's going to decrease the pressure changes downstream. Then we have a second type of artery. From the large elastic arteries, we now have the muscular arteries. These are distal to the elastic arteries, and they'll be delivering blood to the body organs. They have a very thick tunica media. That means they have more smooth muscle in them because they're very active in vasoconstriction and vasodilation. They basically will control where in the body the blood will be going to most at any one particular time, depending on the needs of the body. The arterioles are the smallest arteries, and they are going to be leading to the capillary beds or capillary networks. These control the blood flow into the capillary beds via that vasodilation and vasoconstriction. So these smaller arteries that we call arterioles, they also are very active in vasodilation and vasoconstriction, directing the blood flow to where it's needed at any particular time. Capillaries are microscopic blood vessels, so that means we can't see we can't see them with the naked eye. Their walls have a very thin tunica intima. The smallest capillaries they're only one cell across, so the entire circumference is only big enough to allow one cell at a time, one blood cell that is. There are little cells called pericytes that help stabilize the walls. And again, the diameter of these teeniest capillaries allow only one single red blood cell to pass at a time. So in the capillaries, these are found in all tissues except the cartilages throughout the body, the epithelia, the cornea and lens of the eye. They provide direct access to almost every cell in the body. What are the functions of capillaries? They perform exchange of gases, or they allow the exchange of gases, nutrients, and wastes with the body cells. They also deliver hormones between the blood and interstitial fluid, or that fluid actually surrounding the cells. And then from the interstitial fluid, the materials will be exchanged with the actual cells. There's three structural types of capillaries: continuous capillaries, fenestrated capillaries, sinusoid capillaries or sinusoids. Continuous capillaries are abundant in your skin and muscles. There are tight junctions that connect the endothelial cells together, but there are intercellular clefts that allow passage of fluids and small solutes. The continuous capillaries of the brain are very unique. They have tight junctions which form what we refer to as the blood-brain barrier. And here's a figure of the continuous capillary. They have some permeability, but they're the least permeable of the three types of capillaries, and they're also the most common. Fenestrated capillaries, they actually have many endothelial cells that contain pores or openings. These are referred to as fenestrations. They're more permeable than the continuous capillaries. Their function is for absorption or infiltrate formation at the level of the small intestines, the endocrine glands, and these are also found in the kidneys. And here is a figure of a fenestrated capillary. They have large fenestrations or pores, and they're pointed out for you right here. They also have these intercellular clefts. These again occur in the kidney, by the small intestine, and the endocrine glands, in areas where there's active absorption into the blood or filtration, where fluid comes out from the capillaries into the interstitial fluid. Sinusoid capillaries, they have fewer tight junctions. They're usually fenestrated. They have larger intercellular clefts and large lumens. The blood flow here is sluggish, and because it's supposed to be modified in some way at this point, and this sluggish blood flow allows for modification. Large molecules and blood cells will pass between the blood and the surrounding tissues. We find these only in the liver, the bone marrow, the spleen, and the adrenal medulla. There's also macrophages here that can destroy any bacteria. And here's a figure of a sinusoid capillary. We will talk about these when we get to studying the liver. For one thing, we also refer to it at the level of the bone marrow when we talk about blood cell production, and actually we talked about that already in chapter 17 about blood. We also find these in the spleen. Here's the large intercellular cleft, and you can see why these are the most permeable type of capillary. Capillary beds or capillary networks. These compose what we call microcirculation. These are interwoven networks of capillaries between the arterioles, the smallest arteries, and the venules. These would be the smallest veins as blood is being sent back to the heart. We go from venule. There are actually precapillary sphincters that regulate the blood flow into true capillaries. Blood may go into the true capillaries or may go into a shunt, and this is illustrated right here. So you can see from the terminal or the final arteriole, blood will go into this capillary network, and if necessary, you can see here there's a little, the sphincter is closed, so the blood will bypass this little capillary network. If it goes through the capillary network, of course, the blood will then go through these capillaries here that are represented in the blue because this is deoxygenated blood, and go back into the venules, into the veins. But there are times when blood needs to be shunted past these. An example would be at the surface level of the skin. If body temperature is dropping, the blood will be shunted away from these little teeny capillary networks so that it will conserve body heat. And the individual may look somewhat pale. Around the lips particularly, you may see a bluish tinge. We call that circummoral cyanosis. But depending on the needs of the body, there are times where blood would be shunted so that it won't go into every single little capillary network. Venules. So venules form when the capillary beds unite. The smallest post-capillary venules are very porous. They allow fluids and white blood cells into the tissues. The larger venules are one or two layers smooth. They have one or two layers of smooth muscle cells. Veins will form when venules converge. They have thinner walls and larger lumens compared with the corresponding arteries. Blood pressure here is much lower than in the arteries. There's a thin tunica media and a thick tunica externa to support the vein with many collagen fibers and elastic fiber networks. We call these capacitance vessels or blood reservoirs, and it can contain up to 65% of the blood supply at any one time. The veins have adaptations to ensure the return of blood to the heart despite low pressure. They have large diameter lumens that offer very little resistance, but there are venous valves that prevent the backflow of blood. We see venous valves most commonly. They are most abundant in the veins of limbs. Venous sinuses are actually flattened veins with extremely thin walls. We see this in the posterior side of the heart in what we call the coronary sinus of the heart, and also in the dural sinuses of the brain. And this is that same picture. You can see the artery represented in cross-section here, very thick tunica media, and a vein, very thin in relation to the artery. Vascular anastomoses. These are interconnections of blood vessels. Arterial anastomoses are alternate pathways to a given body region. We see them most commonly at joints, abdominal organs, the brain, and in the heart. There are none in the retina, kidney, or the spleen. There are also vascular shunts of the capillaries, which we saw a few slides ago, and these are considered arteriovenous anastomoses. Venous anastomoses are the most common. Now we're going to talk about blood flow. So what is blood flow? Blood flow is the volume of blood flowing through a vessel, organ, or the entire circulation in a given period. Typically, it's measured as milliliters per minute, and you can see ml per minute, and it's equivalent to cardiac output, represented CO. This doesn't mean carbon monoxide in this context, cardiac output for the entire vascular system. We're going to be talking about cardiac output also. So, blood flow is relatively constant at rest. It will vary widely through individual organs, however, based on the body's needs. Now, what is blood pressure? I'm sure you've heard the term blood pressure many times before. Typically, we abbreviate it BP. This is the force per unit area exerted on the wall of blood vessel by the blood. And this is going to be expressed in millimeters of mercury, because when they used a sphygmomanometer, which is a pressure measuring device, you've probably seen the cuff that goes around typically someone's arm in order to measure their blood pressure. As the pressure is registered, it will be transferred to a column of mercury in a blood pressure measuring device. And then the higher the mercury level goes, that's representing a higher pressure. Blood pressure is typically the measure of systemic arterial blood pressure in the large arteries near the heart. There's a pressure gradient that provides the driving force that keeps blood moving from higher to lower pressure areas. Then there is a term called resistance. Typically, this is referring to peripheral resistance. This is opposition to blood flow. It's the measure of the amount of friction that blood encounters with the vessel walls, generally in that peripheral or systemic circulation. There are three important sources of resistance. One, blood viscosity, or the thickness of the blood. Two, blood vessel length. And three, blood vessel diameter. So the factors that remain relatively constant in influencing resistance would be blood viscosity. Typically, our blood viscosity remains about the same. This is viscosity is the thickness of the blood due to the formed elements and plasma proteins. Occasionally, there may be an increased viscosity if someone is severely dehydrated, or if they are taking erythropoietin, for example, from the outside, increasing the number of red blood cells that their body produces in an abnormal way. This would cause an increased viscosity, which would increase the resistance. But typically, blood viscosity will remain the same moment by moment. Blood vessel length, the longer the vessel, the greater the resistance. And this, of course, doesn't change much except over your lifetime as a person grows in stature. But the third element, blood vessel diameter, this has the greatest influence on resistance because changes in the vessel diameter alter the peripheral resistance. If the radius is narrowed by 1/2, the resistance will become 16 times greater. Therefore, as if the blood vessel constricts, it's going to greatly increase the resistance here. The small diameter arterioles are the major determinants of peripheral resistance. Now, if there's abrupt changes in diameter of that vessel or over a long period of time, relatively long period of time, if there are fatty plaques or buildup of plaques on the inside walls, we call that atherosclerosis or arteriosclerosis. This will dramatically increase resistance, and of course that increases a person's blood pressure on a chronic basis. So now, what is blood pressure? Systemic blood pressure was when we were measuring it out in the body. The pumping action of the heart generates the blood flow. So pressure results when flow is opposed by resistance. Systemic blood pressure is highest in the aorta. and that's where blood is going to be pumped out from the left ventricle out to the body. The pressure will decline throughout the circulatory pathway, and it reaches 0 millimeters of mercury in the right atrium. You notice this is blue. The right atrium receives the deoxygenated blood from the body. Anyway, the steepest drop is going to occur out in the arterioles. And here's a figure that represents blood pressure in the various blood vessels of the systemic circulation. Here's the blood pressure in millimeters of mercury, and they're indicating which type of vessel along this x-axis here. Y-axis, x-axis. So, and they're even showing you systolic and diastolic pressure, which will be explained in just a minute. So, arterial blood pressure reflects two factors of the arteries close to the heart. One, elasticity or compliance, how elastic they are. And two would be the volume of blood forced into them at any one time. The blood pressure near the heart, of course, is pulsatile, because as the ventricle contracts, a volume of blood out into that artery, the pressure increases. When the ventricle relaxes, that pressure will be lower. Systolic pressure, that is actually the pressure exerted on the aorta during ventricular contraction. We refer to ventricular contraction as systole, S-Y-S-T-O-L-E, with a long E sound. So, systolic pressure is that pressure exerted on the aorta during ventricular contraction, and it averages about 120 millimeters per mercury in a normal adult. Everyone's is a little bit different, but this would be the average. Diastolic pressure is the lowest level of aortic pressure, which is about 80 millimeters average, 80 millimeters mercury during ventricular relaxation. And diastolic pressure of individuals, it will vary a little bit around that number as well. Pulse pressure is defined as the difference between systolic and diastolic pressure. And this is there's actually also a throbbing of the arteries. You can feel a pulsation. When we feel the pulse, that would be in an artery. Palpation means you're using your fingers in order to feel that pulsation of the blood flow. There's something called mean arterial pressure. They represent an MAP. This is the pressure that is propelling blood to the tissues. This mean arterial pressure equals the diastolic blood pressure plus 1/3 of the pulse pressure, or the difference between diastolic and systolic pressure. The pulse pressure and the mean arterial pressure decline with increasing distance from the heart. Capillary blood pressure ranges from 17 to 35 millimeters mercury. Low capillary pressure is desirable. High blood pressure here would rupture these fragile capillaries. Most capillaries are very permeable, so pressure will filtrate a fluid from the bloodstream out into the interstitial spaces around the body cells. We call that tissue fluid. If it's excessive, we call it edema. Venous blood pressure. It doesn't change much at all during the cardiac cycle. The smallest pressure gradient is about 15 millimeters of mercury. The low pressure is due to the effects of peripheral resistance. So what aids venous return? We have a muscular pump. It's not directly associated with the veins, but it would be the contractions of the skeletal muscles around those veins. There's also the valves that are present in the veins that prevent backflow. In the thoracic area, we have the respiratory pump, and this is defined as the pressure changes during breathing. These will move the blood toward the heart by squeezing the abdominal veins, and then the thoracic veins would expand. We also have venoconstriction, sympathetic nervous system. This can happen somewhat, and this will push the blood toward the heart. And here's an illustration that represents what's going on with the veins. This is kind of an artificial setup here, but you can see that these would be contracted skeletal muscle. It's actually, as these contract, they're pushing that blood back to the heart, and the valve here is closed, so therefore the blood can't go backwards. Maintaining blood pressure. So through the cooperation of the heart, the blood vessels, and the kidneys, and supervised by the brain, the main factors influencing blood pressure are cardiac output, peripheral resistance, and blood volume. Cardiac output, CO. Cardiac output equals stroke volume times heart rate. Normal is about 5 to 5.5 liters per minute. It's determined by venous return and the nervous system, neural, and hormonal controls. Resting heart rate is maintained by the Cardiovascular Center. That means inhibitory, it's actually part of that parasympathetic nervous system, the parasympathetic vagus nerves. So this would be at rest. Stroke volume is controlled by venous return, and venous return will determine end diastolic volume. This is discussed in chapter 18. End diastolic volume, remember, would be the amount of blood in the ventricle just before the ventricles contract. So as the ventricles relax during diastole, it's just wide open and receiving blood. Just before systole, the volume in that ventricle is called end diastolic volume. During stress, there is something called the Cardiovascular Center. It's going to increase the heart rate and stroke volume because this center is activated by the sympathetic nervous system. And here is the factors that enhance cardiac output. And I'm not going to go over this. You can look at this for a while. It's just summarized from the information in the slides. I also have a handout for you that is in your Canvas module. Control of blood pressure. There are short-term neural and hormonal controls. They counteract the fluctuations. In other words, they alter peripheral resistance and cardiac output. There's also long-term renal regulation that can alter blood volume. So as blood pressure goes up and fluid is delivered to the kidneys, any excess water will be removed by the kidneys. If there's not enough water in the system, the kidneys will conserve that water to keep your blood pressure high enough in order to allow blood to circulate. Short-term mechanisms, neural controls. If the blood pressure is low, all the vessels are going to be constricted except to the heart and the brain, the essential organs. It'll alter the distribution of blood to the organs in response to specific demands. There's also some reflex arcs involving baroreceptors. Have you ever heard of a barometer? Baro is referring to pressure. So in the body's blood vessels and in the heart, there are areas where there's little pressure receptors. So reflex arcs can occur that involve these baroreceptors. The Cardiovascular Center, which is located in the medulla oblongata of the brain. Vasomotor fibers that are synapse with the heart and vascular smooth muscle. Chemoreceptors in the blood, and also higher brain centers can influence this. The Cardiovascular Center is actually sympathetic neurons in the medulla oblongata. It will respond to changes in cardiac output and blood vessel diameter. The Cardiovascular Center receives input from the baroreceptors, chemoreceptors, and higher brain centers. An example of a chemoreceptor would be responding to levels of oxygen or CO2 in the blood. Baroreceptors, we find these in the carotid sinuses, in the carotid arteries, the aortic arch, and the walls of the large arteries of the neck and thorax. If there's an increased blood pressure, this will stimulate baroreceptors to increase input to the vasomotor center to inhibit the vasomotor and cardioacceleratory centers, and this is going to then cause arteriolar dilation and venodilation. It will also stimulate the cardioinhibitory center, the result being a decrease in blood pressure to bring it back down to normal. There's also a short-term mechanism related to the baroreceptor reflex, and when blood pressure drops due to arteriolar dilation, venodilation, or decreased cardiac output, you have reflex vasoconstriction, and then this will increase the cardiac output, which will then, of course, increase the blood pressure back up to normal. Upon standing, the baroreceptors of the carotid sinus reflex will actually protect the brain. You may have seen pictures too of people that are standing for a long period of time. They can suddenly pass out because it's going to affect the baroreceptors in the carotid sinus that are going to the brain. And sometimes when people stand up very quickly, they can pass out because they're overcoming this carotid sinus reflex. They have kind of low blood pressure to begin with, and therefore the blood is not delivered as quickly to the brain when they stand up suddenly, and you can pass out then. And here is the baroreceptor reflexes summarized. Here you've got increased blood pressure. Arterial blood pressure goes too high, baroreceptors are stimulated. This sends the message from the baroreceptors to stimulate cardioinhibitory center. This is going to decrease sympathetic impulses to the heart, causing decreased heart rate, decreased contractility, and decreased cardiac output. Then, and also, you have a decreased rate of vasomotor impulses, allowing vasodilation, and here you have a decreased cardiac output, decreased resistance, helping to return blood pressure to normal. And again, here's showing the opposite. The blood pressure drops, arterial blood pressure falls below normal. The baroreceptors, which they're showing right here, in the carotid sinus, are inhibited. So then we have the decreased impulses from baroreceptors are activating the cardioacceleratory center. This will increase sympathetic impulses to the heart, increasing heart rate, increasing contractility, and therefore cardiac output. And then you have increased cardiac output, increasing resistance, brings that blood pressure back up to normal. Short-term mechanisms, this is the influence of higher centers. We have reflex centers in the medulla oblongata. The hypothalamus and the cerebral cortex can actually modify arterial blood pressure via input to the medulla. This is when we think about someone that is a type A personality or you're under a lot of stress. It can actually increase your blood pressure. There's also hormones, epinephrine or norepinephrine from the adrenal medulla, the inner area in the medulla, adrenal medulla, increase cardiac output. Angiotensin II will cause vasoconstriction that will increase cardiac output. Antidiuretic hormone, which will serve to conserve water, it will increase the conservation of water by the kidneys, increasing blood pressure, and it will also lead to vasoconstriction. These all increase blood pressure. A hormone that decreases blood pressure is called the atrial natriuretic hormone, and that is produced by the atrium, is put into the blood and circulates throughout the body, and it will actually then allow decrease in blood volume by antagonizing a different hormone called aldosterone. And we will be talking a lot about hormones when we get to the endocrine system. Renal regulation. Baroreceptors will quickly adapt to chronic high or low blood pressure, so they can become ineffective long term. Long term, we have mechanisms that will control your blood pressure by altering blood volume via the kidneys, either excreting excess water or conserving water when blood pressure drops. There's a direct renal mechanism that alters blood volume. Increased blood pressure or blood volume causes the elimination of more urine, reducing your blood pressure. A decrease in blood pressure or blood volume causes the kidneys to conserve water, therefore blood pressure rises. Indirectly, we've got this complex system which we will be coming back to when we get to the urinary system. It's called the renin-angiotensin-aldosterone mechanism. A decrease in arterial blood pressure will cause the release of renin by the kidneys. Renin catalyzes the conversion of angiotensinogen, produced by the liver, into angiotensin 1. Angiotensin converting enzymes that are put out by the lungs will convert angiotensin 1 into angiotensin 2. Angiotensin 2 then goes to the adrenal cortex and will stimulate the release of aldosterone. Aldosterone secretion will increase blood volume because it conserves sodium. We're going to be talking about, I just mentioned it now, we will be talking about it more when we get to the kidneys. And here is showing you the summary of all these things. I'm just going to skip through here. These are factors that increase the mean arterial pressure. Well, how do we monitor circulatory efficiency? What we call vital signs. Pulse. Typically we feel that at the radial pulse by the radius at the wrist. Blood pressure. We take blood pressure, respiratory rate, and body temperature. Pulse is actually that pressure wave caused by the expansion and recoil of the arteries. And again, the radial pulse is routinely used. There are others. There's pressure points that are the locations where arteries are close to the body's surface that we can actually use to stop bleeding if there's a hemorrhage. And here's showing the pulse where you can feel pulse. If with children, if you are checking their blood pressure, so if all you have is an adult cuff, you can actually use the thigh, put the blood pressure cuff on the thigh right here, and the popliteal artery in the back behind the knee. That's a good location to feel the pulse because we need to be able to palpate the pulse during blood pressure determination. Here's posterior popliteal, posterior tibial artery. Dorsalis pedis artery is on the top here of the foot. Measuring blood pressure. In order to measure systemic blood pressure, we use a sphygmomanometer. We will be doing this in lab. The pressure is increased in the cuff until it exceeds, so we'll use like a little, it's like a rubber bladder inside there, they call it, and then you will actually fill that with air. And so we're increasing the pressure in the cuff until it exceeds the body's systolic pressure in the brachial artery. The pressure is released slowly, and then you'll be listening to for sounds. And the first sounds that are heard are called sounds of Korotkoff, and you're listening with the stethoscope. Systolic pressure is determined when you first hear the sounds. So the pressure when the first sounds occur as the blood starts to spurt through the artery. Because when you've pumped that cuff up, it's beyond the pressure in that artery. If it was left pumped up really high, you're actually cutting off the circulation. So when you begin to release that pressure, you'll hear a sound, and that is considered systolic pressure. Diastolic pressure is defined as the pressure when the sounds disappear. The artery is no longer constricted and the blood is flowing freely. Obviously, these are related to your hearing acuity if you're the practitioner. So we have other types of equipment where we can automatically measure blood pressure without having to hear the sounds begin and then stop. Average 120/80. Variations in blood pressure. There's transient elevations during changes in posture, physical exertion, emotional upset, pain, and fever. So your blood pressure never stays exactly the same. There will be variability when you're working out. It should go up and then return to normal when you're just relaxing. Age, sex, male or female, weight, race, mood, posture, all can cause blood pressure to vary. Hypertension is defined as high blood pressure that is sustained elevated arterial pressure of 140/90 or higher. Prehypertension is also something that they're looking at where the values are elevated but not quite to the point of 140/90. And this would be over a period after more than one measurement that you would actually define hypertension or prehypertension. Prolonged hypertension is a major cause of heart failure, vascular disease, renal failure, and stroke. 90% of hypertension is not, we don't know the cause. This is called primary or essential hypertension. There's no underlying cause, but the risk factors for developing this it's a hereditary thing. If your parents, grandparents have had it, you're more likely to have it. The type of diet someone is eating, obesity as you get older, having diabetes mellitus, stress, and cigarette smoking. All of these factors increase your risk for hypertension. There's no cure, but you can have a control. If a person develops this, they can restrict salt, fat, and cholesterol, increasing exercise, losing weight, stopping smoking, and there's a large variety of antihypertensive drugs available. Secondary hypertension is less common, but it would be due to an identifiable disorder, obstructed renal arteries, kidney disease, or endocrine disorders. In children, if a child has high blood pressure, it would be a red flag signaling that it could be a kidney disease. Treatment for secondary hypertension is to correct the underlying cause. Low blood pressure is called hypotension. This is when blood pressure is less than 90/60 millimeters per mercury. It's not usually a concern unless there's not an adequate blood flow to the tissues. People who have low blood pressure are much more likely to have what we call postural hypotension. And that's when you get up quickly from the lying position especially, and there's not adequate blood flow to the brain, and that can cause a person to pass out. That's actually called orthostatic hypotension, the temporary low blood pressure and dizziness when a person suddenly rises from sitting or reclining up to standing up. Acute hypotension is an important sign of circulatory shock. Bulk flow. This is when there's fluid leaves the capillaries at the arterial end. Most of it will return to blood at the venous end. So this would be when fluid's filtering out. This determines the relative fluid volumes in the blood and the interstitial spaces. The direction and amount of fluid flow depend on two opposing forces. Hydrostatic pressure, that's water pressure, the pressure in the circulatory system, and the opposite would be colloid osmotic pressures. This is due to the proteins within the blood that keeps the fluid within the blood vessels. Capillary hydrostatic pressure tends to force fluids through the capillaries walls. Interstitial fluid hydrostatic pressure is usually assumed to be zero because the lymphatics or the lymphatic vessels are draining that excess interstitial fluid. That capillary colloid osmotic pressure or oncotic pressure, this is created by those non-diffusible or non-filterable plasma proteins such as albumin that stay in the blood vessels, and they're going to draw water toward themselves. Circulatory shock is any condition in which the blood vessels are inadequately filled. The blood cannot circulate normally, and this will cause an inadequate blood flow to meet the body's tissue needs. Hypovolemic shock is when there's an enormous amount of blood loss. Vascular shock is when there's extreme vasodilation and a decrease in peripheral resistance. Cardiogenic shock is when there's a failing heart that cannot sustain adequate circulation. And that is the end. Have a wonderful day. I will see you next time.